You know that dizzy feeling you get when you stand up too fast from the couch? That happens because gravity temporarily pulls your blood in your legs, causing the pressure in your brain to drop. Identifying that corrective loop is the specific challenge posed here, in an exam prompt asking for the mechanism of baroreceptors and arterial pressure. Physically, the body only has two variables it can manipulate to correct that drop. It can adjust how hard the heart pumps, your cardiac output, or how tight the vessels are, your total peripheral resistance. No matter how complex the nerve pathways or hormonal cascades get, every single physiological response we cover will target one of these two variables. When pressure drops suddenly, the body has only seconds to react. That timeline requires the lightning-fast electrical signaling of the nervous system. This diagram highlights the locations of the body's pressure sensors, called baroreceptors. You will find them stationed high in the neck at the carotid sinus and just above the heart in the aortic arch. These receptors operate on a specific physical trigger. When blood pressure drops, the vessel walls stretch less. That lack of stretch causes the nerve's firing rate to physically slow down. Up in the brainstem, the medulla interprets the quiet nerve signal as an emergency. In response, it unleashes a wave of sympathetic activity back down toward the chest. Tying this back to our equation, that sympathetic response increases heart rate to boost the pump and constricts vessels to tighten the pipes. The pressure stabilizes and the patient does not faint. But what happens during a prolonged stressor, like severe dehydration? Nerves fatigue over time. For a durable fix, the body relies on chemical signals from the kidneys. We can map out this chemical cascade, known as REAS, right here. A drop in pressure prompts the liver to produce angiotensinogen and the kidney to release renin. Together, they form a prohormone called angiotensin I. As blood passes through the lungs, an enzyme called ACE is injected into the pathway, converting that precursor into the highly potent angiotensin II. Angiotensin II acts as a powerful vasoconstrictor. In our baseline equation, clamping down those blood vessels directly maximizes total peripheral resistance. Think of the equation. If angiotensin II has fixed the TPR side, what hormone must it trigger next to fix cardiac output? And what is its mechanism? Pause the video and consider the answer. The second half of the fix happens at the adrenal cortex. Angiotensin II triggers the release of aldosterone, which forces the kidneys to save sodium and water, physically increasing total blood volume. Increasing blood volume means more fluid returning to the heart, which increases stroke volume. That resolves the cardiac output half of the equation for long-term stabilization. Let's apply this to a patient in hypovolemic shock due to severe blood loss. They arrive in the ER with a racing heart, cold skin, and zero urine output. Those symptoms align with the mechanics we've mapped. The racing heart and cold skin are the short-term baroreceptor reflex, driving sympathetic vasoconstriction. The lack of urine is the long-term RAS system, with aldosterone holding on to every drop of water. This specific interplay between neural and hormonal systems is the standard required for a full evaluation of arterial blood pressure. This cheat sheet summarizes the dual mechanisms. Whether the body relies on a split-second neural response or a multi-day hormonal cascade, the solution always comes back to balancing the pump and the pipes.